Where did the years go so quickly, my love? How did we get to be gray? Decades go by in the blink of an eye. It still feels like just yesterday. The first time that I heard you say, love me forever and hold me right now. Gather our memories like this. I know we'll never be old anyhow. Anytime we reminisce, I'll be as young as your kiss.
Okay, ladies and gentlemen, we're going to get started. My name is Joe Zapata. I'm with the University of Texas Health Science Center, and I am the CEU coordinator, conference coordinator, and part of the committee member. And I'm going to be talking about the statement of attendance for those who are seeking continuing education credits. So, can you hear me now? Better? Okay. So, looking at the first form is your statement of attendance form. On the front, it shows the CEUs that we are providing today. On the back is the form that you must fill out to receive credit. Be sure to signify on the bottom which one, only one CEU you are selecting today. We will be providing the CEUs via email, so please put down the email address you want it to be sent to. Make sure you sign and print. And on the bottom of the columns and rows, make sure you put in the credits that the amount of credit that you are applying for. And you must attend 100% of the conference to receive credit. And you must turn this in at the end of the conference. I will not accept these during the conference, only at the very end. And of course, if anybody has any questions pertaining to CEUs, you can find me. I'll be up and around the back up there. And be sure to read the instructions carefully. The next sheet is the participant profile. Looks like this. It's a demographic profile that is used for funding purposes. People in the past have filled out this participant profile and have been able to bring funding to us so we can provide this conference to you. So by doing so, you provide conferences for future events pertaining to the Alzheimer Association and further events pertaining to geriatrics. On the front, available are additional forms to participate in other conferences in the future, primarily the Summer Student Aiding, the Alzheimer Summit in San Antonio, and a couple other events that are taking place in South Texas. So during the next break, take a look at that and probably register or take a read through it to see if that interests you. Again, my name is Joe Zapata. I'll be up and around, and if you have any questions pertaining to CEUs, please come up, don't be shy, and I'll be sure to help you out or at least point you in the right direction. Now here is Joe Carroll, going to introduce our next speaker.
Does it scare you when they say Joe Carroll and you think I'm going to speak about something? I had a whole page prepared because usually Dr. Mahindalay picks on Dr. Goldman so much that I felt like I would have to give him accolades. But he did a pretty good job. Dr. Mahindalay kind of laid off of you a little bit today. Dr. Mark Goldman is licensed as a psychologist by the Texas State Board of Examiners of Psychologists and provides clinical services to include psychotherapy and psychological testing. He treats anxiety, depression, stress, and pain management related problems. He also sees individuals with severe and persistent mental illness, bipolar disorders. He tests for assisting in diagnosis and managing dementia. He helps people with attention deficit disorders, behavioral problems, and brain trauma. And after I went over that list, I really thought you should add, if you've got 4 or more of these, just a place to make an appointment right then. I kind of wondered about myself. Dr. Goldman has 30 years of experience. He treats ages 8 through seniors. He was formerly the director of psychology at the Kerrville State Hospital. He serves as a consultant to Peterson Regional Medical Center. He's a member of the Biomedical Ethics Committee. He is a consultant to Starlight Treatment Center, Bandera Sheriff's Department, and Kerrville Police Department. And he's also co-authored with Dr. Mahindale on publications. Thank you so much, Dr. Goldman, for coming.
Okay, everybody can hear. Yeah, this is on. Good. All right, as you can see, this is not the mini Goldman. This is the full-size Goldman. You can watch me now as I make the decision about where I'm going to place my water. Now, if I put it up here, and you'll understand why I'm doing this a little bit later, because I'm a psychologist and I can't give any straight answers. You know, I have to answer questions with another question or tell stories and things like that. But if I put my water here, my glass is kind of full. This table, you can't see it, it's kind of at an angle, so I risk it falling over. Now, but it might be more convenient because I'm tall. But if I put it over here, well, that's pretty dangerous, especially for somebody who's kind of clumsy like me, and I would probably knock it over, hit the keyboard, and that'd be the end of my PowerPoint, and I'd be in big trouble. So I may not put it over there. So thinking about that consequence, maybe the best place is to put it over there, because if it does spill, hopefully it won't knock out the computer. Ooh, I didn't see this. I better be careful. Okay, there's some wires up here, so if I get too close, somebody send me a warning. And like I said, I'll go through that in a minute. And I thank Joe Carroll very much for the kind introduction. You know, it was kind of, Dr. Mahindale and I have worked together 30-odd years. I tell him sometimes we kid around. I've known Dr. Mahindale almost as long as I've known my wife, which is, you know, it'd be kind of a weird thing. Anyway, you know, they say when spouses are together for a long time, they start to behave in the same way, maybe they even start to look alike. Well, in the 30 years I've known, and he's not even here to hear this, which really bugs me, you know, because I'm trying to get back at him now, and he's got some, no, it's not appointments, it's his phone. He's worried about his phone. But anyway, so in the 30 years I've known Dr. Mahindale, he hasn't grown a bit. So, you know, and most people say when they look at us, they can see, you know, little distinguish some differences, and most people say, yeah, I'm the pretty one, so I thank him for that. And you probably heard him when he spoke. I don't think you picked up his Brooklyn accent. You may pick up mine as I speak and go along. But anyway, so we've known each other, like I said, for 30 years, and I'll get on to my program in just a minute. But you may wonder why I didn't react when he lost his phone. And if you work with him for any length of time, you know that him losing his phone, losing his pen, losing his glasses, losing his coffee cup, his jacket. Yesterday morning I had to chase him down. He left his jacket in my office. About a year ago, only he and I were up in the office. This is a Mahindale story. He's got plenty about me, but he's not here, so that's too bad. I get last licks, as they say. Anyway, about a year ago, I'm up in the office, and he's down in, we share an office, a suite of offices, and he's down in his office. You know, Goldman, Goldman, Goldman. What's the matter? I can't find my phone again. I said, not again. He said, I've looked all over the office. All right. You look. Will you look with me? So I'm trying to do some work, and now I'm interrupted, and we do the whole survey of the office. Can't find it anywhere. I said, you know, Anna, I don't know where it is. It's not up here. So, well, let's go in the elevator. It's dark outside too, you know, it's early in the morning, we're up there early in the morning. So he said, let's go in the elevator, we'll check the elevator. I go in the elevator with him. I don't know why he needs me to go in the elevator, but he's so absent-minded he may have, you know, who knows what. And there's 2 elevators. He couldn't remember which one he came up in, so we had to do both elevators. Fortunately, I know he doesn't do the stairs, so we didn't have to worry about that. He didn't go into the restroom, so I didn't have to follow him in the restroom. And there's cameras. I don't want to see that on camera. You know, I follow him into the restroom. So yeah, it's not. So all right, let's go outside. All right, well look. Well, do you have a flashlight? No, but well, I have a light on my phone. Not going to do us a whole lot of good now. So we go out there. We trace. We walk through the parking lot in the dark. Go up to his car. It's not in his car. Search all over his seats and all of this. I said, I don't know where it is. At that point, he remembers, oh, I have this locator thing on my computer for my phone. All we have to do is go up in the office and it'll... So, where's his phone? He left it at his house. After all that searching, about 30 minutes. All right, one more quick story about that, then I'll get started. Another phone story. Now, because of the way Dr. Manley is, he cannot tell a fib, or if he does, he has to, you know, rectify that. So, again, was this about a year ago with the phone when he told us that?
Yeah.
So he goes to Austin periodically because he has to do some meetings, etc. in Austin. So, while he's away, staff try to get a hold of him, and they cannot get a hold of him. So he comes back, and we said, well, what happened to your phone? What happened to your phone? We tried calling you, we couldn't reach you. So, oh, I dropped it, and it got wet. Well, how did that happen? Well, I was at the table, I was bending over, and it fell into my teacup. Yeah, right. How many people can drop a phone in their teacup when they're trying? You know, they're just teacup. So he tells us that story, and then, you know, because he has to, he's committed to this, he has to come back later and tell us the truth. Which was he dropped it in the commode, which we all knew anyway. So those are my 2 stories, and like I said, the sad part is he's not here to hear any of that. So that's kind of annoying. Now, uh-oh, what did I do with my papers?
Right here. Other side of the
There they are. Just as bad as he is. Oh my gosh. This is horrible. No, it's all right. It'll be all right. That's what we say in our office. It'll be all right. Don't worry until we tell you to worry. That's what we say. So I practice psychology and I do neuropsychology. And today, my topic is going to be an overview of Alzheimer's disease. And we're going to look at the importance of neuropsychological testing, which is what I do, and also the early detection of cognitive changes, which is quite important. As I get started today, I'm going to switch the roles around a little bit. Periodically, there are going to be slides that are kind of like self-test slides. So I'll be asking you questions, and there's a spectrum. Some people are quite introverted, some people are quite extroverted. There's that spectrum, and I'll tell you why I'm talking about spectrum in a minute. Again, you'll have to wait. This keeps you in here instead of everybody going out and having a break. But there's a spectrum, and neither end is bad, but that's the normal variation in personalities. Introvert people who like to keep to themselves. They're not the sales type people. They often prefer to work in labs or with things rather than other people at one end. The other end is the extrovert, who is very engaging socially, usually are involved in speaking, perhaps sales. They do very well as salespeople because they're, you know, quote, the people. So, getting back to it, when I hit the slides that are self-tests, if you're on the introvert end of the spectrum, and I'm a psychologist, I don't like for people to feel bad about themselves. So if you are, that's okay. You don't have to raise your hand, okay? You don't have to respond. If you're on the far end of the extrovert spectrum, I'm going to ask you to use your prefrontal cortex in the frontal lobe to inhibit your responses a little bit. So don't be like the kid in the class, I know, teach. No, don't do that. Just, right, Renee? Just raise your hand, that'll be fine. And if you don't, and you're on that introverted end, that's okay too. You don't have to. Okay, you can do the test in your mind, or the question in your mind. Now, the reason I brought that up is because Alzheimer's disease, and I'll use those terms interchangeably, Alzheimer's disease and Alzheimer's dementia, is actually what we call a spectrum disorder. Okay? So it can start, as we mentioned, even before we may notice outright symptoms, 10 or 20 years sometimes before a symptom picture starts to emerge, all through the spectrum, what we call mild cognitive impairment, through the spectrum of early stages, mid stages, and severe or end stages. It's a spectrum, and it progresses. And it doesn't progress like we see it in the book. As a matter of fact, I've never seen anything in all the books that I've read where it just progresses like it's in the book. In real life, it's different. There are a lot of other complicating factors and variables. So somebody may be mild on some domains, we'll talk about more about domains later, and maybe more moderate stage in another domain. So it doesn't flow, like I said, in a book. The other thing I just want to share with you personally, my grandmother on my maternal side suffered with dementia, likely Alzheimer's disease or Alzheimer's dementia. And now my mother, who is 84, probably is in the mild to getting into the moderate stages. So, you know, not only do I talk about it and test people with it, I deal with it. My dad works with it on a day-to-day basis, helping my mom, and I've watched the progression both in my grandmother, which was way before I was a psychologist, and now see it in my mother, and I am a psychologist. I do neuropsychological testing, so I can see the progression in person. So I'm not a stranger to it, is what I'm trying to say. I'm not somebody who just tests people, and it's not touched by, you know, in a personal way. I've got so much to manage here, it's going to be crazy. Where's my clicker? I need another hand, because no. All right. So early on, you saw that I did that little decision-making thing. Where do I put my water? Yeah, and it was probably kind of strange, but I did that just as an example. One of the things, and we'll get into this a little bit later in the slide, but I did that intentionally. Although there are a lot of things I do by accident, and I try to just blend them in anyway. But that was actually done intentionally, because I was demonstrating to you what's executive functioning. Sometimes that's a domain or a neurocognitive or cognitive skill that's difficult to explain. But what I was doing, talking out loud, I was planning and taking into account the consequences of different behaviors that I could engage in. That's what part of executive functioning is. And I was looking at, well, you saw if I put my water up here, although it's more convenient because I'm tall, it might very well spill easily because it's on an angle. If I put it down here, my executive functioning, again, thinking about the consequences of a behavior, well, it'll be right in front. I move around a lot. My arms are long. I could very easily knock it over, land on the computer. That would be a bad outcome. So the safest place, as I process this information, would be to put it back there, as long as I don't pull all the wires out. Yeah, thank you. And that way, if it does spill, it's less likely to land on the computer. It may make a mess, but probably my PowerPoint and everybody else's PowerPoints will still work. So that's executive functioning. And that's a very, very important part or aspect of one of the domains that neuropsychologists test as we look at Alzheimer's disease or Alzheimer's dementia, and one of the things that over time often changes, the executive functioning part. So we'll talk more about that. And as I talk, I'll be weaving in different aspects of why it's important to detect it early, how we detect it early, etc., etc. So I'm going to try to blend a whole bunch of information. Some of it Dr. Mahinley talked about. I will try not to... Oh good, you're going to put an extension cord in? We're just going to pull it out, that's probably safest. Okay, and some of it may be that I'm talking about what he's already talked about, but coming at it from a different angle, which I hope will solidify knowledge. So let's go to my first slide. That's not it. Uh-oh. All right. Oh, a self-question number one. All right. Now remember you extroverts, okay? Don't have to jump up and yell. Can everybody see that or no?
Yes.
Okay. Self-knowledge. I'm not going to read it because that's kind of foolish. I'll give you a few seconds to look at that. Everybody read it already? All right. Let's take a vote. Who wants to go for number one? Anybody for number one? Oh, okay. How about number two? A lot of people voting on number two. Number three. How about number four? All right. What is dementia? The key in that definition is that it's not always memory loss. Can be, but memory loss is just one part of it, but is severe enough to interfere with everyday life, with an individual's everyday life, their everyday functioning. And that's, as you can tell, that's not an exact measurement, and it may not be the same for every individual. And the scans and everything we do are very powerful and very good, but they cannot differentiate the severity or lack of severity of the disease. They will tell you you have brain atrophy, this part of the brain has had a stroke, but they cannot, and it can look bad on an MRI or a CAT scan, but it cannot tell you the nature of its severity in terms of how it interferes with daily functioning or everyday life. And that's where the neuropsych testing or neurocognitive testing, I'll use those interchangeably, that's where the testing is quite important. Now the testing that generally a neuropsychologist does looks at a number of domains. The testing that I do looks at 7 large domains, ends up being broken down into 35 to 40 different categories. I'll show you at the end some of the testing that I've done and you can just get an idea about it. But we look at attention, concentration, and what's called processing speed, how quickly an individual can understand and gather information. We look at executive functioning and reasoning, which I just demonstrated for you. We look at learning and memory, both verbal memory, nonverbal memory, and a thing called working memory, which if I have a chance I'll discuss with you later. We look at language skills, the ability to use words to make sense, and the ability to understand information. We look at perceptual, motor, and visual skills, being able to understand distances between objects, depth perception, things quite important also in driving. Social judgment, we talked about that with some of the dementias, understanding what's appropriate, what's not appropriate, understanding verbal and nonverbal cues from other individuals. And we look at personality variables, depression, anxiety, bipolar disorder, attention deficit disorder. All of these are involved in a diagnosis of a dementia, Alzheimer's disease or another type of dementia. Now, Dr. Mahinley gave you the slide on prevalence rates and statistics, so I'm not going to spend a lot of time about that. Prevalence rate in the episodes of new diagnoses of a disorder, and you can see those up there. Those tables are available in a lot of different places, so I'm not going to spend a lot of time on that. Oh, all right, another self-knowledge question. Introverts, feel free to vote if you would like. But you don't have to, it's okay. I understand. So, let's take a look at this one. I'll give you a few seconds to read it. Everybody did great on that first one. Wow, you knowledgeable people, knowledgeable audience. Excellent. I'm glad they have it on both sides because I feel like I'm always in the way, you know. Okay, so who would say number 1? How about number 2? I can look on my sheet. I don't have to keep turning my head. All right, that makes it a little easier. I felt like The Exorcist, you know, it's kind of spinning around here. Number 3. Wow. How about number 4? Oh, this is no fun. Everybody's getting it correct. You know, I'm glad I'm not giving away prizes like a game show. I'd be broke. Yes. Number 4 is correct. So, that's why we look at a lot of different variables when we assess for dementia or cognitive change, and that's why it's a complicated diagnosis. As an aside, a lot of times I get, not a lot, but I don't know, high frequency enough where somebody will come in and they say, well, I took this test on the internet. Okay? Oh, I go, that's a warning sign right away. Oh my gosh, took the test on the internet. Okay, what test did you take? Typically it's the IQ test. Oh, okay, very nice, very nice. And my IQ is 250. No, I'm not saying that to him. First of all, just taking it on the internet drops it by at least 200 points. No. But the standard IQ test, the industry standard for psychologists, are the Wechsler scales, okay? There is no 250 on the Wechsler scales. I've been doing it for 30-something years. 160 is like about the max, and I have, in 30 or 31 years, I've been testing and seeing people. I've never seen anybody get 100. Dr. Mahinley, one of the smartest people I know, probably could get close, but he's not. I mean, I couldn't get 160. I know all the answers. And I still wouldn't be fast enough. Some of them are timed. I still couldn't do it. So, you know, if you want to take those tests on the internet, fine, but really, really take them with a grain of salt. I know there are all kinds of tests for dementia, etc. If you go to some of those sites, go to reputable sites, the Alzheimer's Association sites, Mayo Clinic, some of the sites like that to get, you know, get some of your information, but stay away from some of the others because, I don't know, I've looked at some and I wonder where they come up with that information. All right, getting back to the slide. You know, there are a number of ways to divide dementias, and one of the ways, and Dr. Mahinley hinted at it somewhat, is reversible versus irreversible. And that's very important to know. And that's one of the reasons why the testing, as well as the clinical diagnostic interview, is so important. Because if somebody has a reversible dementia, let's say a thyroid condition, B12 deficiency, normal pressure hydrocephalus, some other kind of metabolic disease, or psychogenic factors or psychological factors that mask as a dementia, such as depression, anxiety, attention deficit disorder. I'll talk about that in a minute because I think that's interesting. We want to treat those right then and there and correct that, because that's reversible. Right now that is reversible, and why should somebody suffer if they don't have to, if we can fix it, okay? But there's a lot. There's not just Alzheimer's disease and vascular dementia. There are a lot of diseases that affect our brain. So that's why it's not such an easy diagnosis. Somewhere between 75 and 100, some reversible, some irreversible. So that's one distinction that's very important to make right at the outset. Are we dealing with something that's reversible? We can treat it with medication, rehabilitation therapy, counseling, psychotherapy, or is it something that is irreversible and we have to treat in a different way? What I want to discuss next, and as Dr. McHenley had mentioned, people come into the office and there is some confusion about dementia, which is the umbrella term for changes in cognitive functioning that interfere with everyday life. Covers those 75 to 100 versus the 4 major types of irreversible dementias that we typically see. Now the reason I'm going into this in a little bit more detail is because of the overlap between these disorders, the different ways you might treat these disorders, and the importance of trying to discern what's happening. The other thing is, because you have one disorder, like Alzheimer's disease, on top of that you can have another disorder, comorbid disorder, depression, anxiety. You could have what we see a great deal of now is a combination we call mixed etiology or mixed etiological disorders, which is Alzheimer's disease along with vascular disease. And the MRIs of the brain show that up often. I think I got too many papers, that's my problem. Okay, so the first one we're going to look at is vascular dementia. And on that slide I just showed you before, 98% of the irreversible dementias that we see are accounted for by these 4 major categories. Dr. McHenley talked a little bit about vascular dementia. Generally accounts for 10 to 20% of that 98%. As he mentioned, one of the hallmarks of vascular disease, usually related to a stroke, is the sudden change, where dementia or Alzheimer's disease is rather a gradual, progressive, degenerative process. Most of the time, the change is quite dramatic after somebody has a stroke. Now, the other thing about strokes, you can have many small strokes and really not display a whole lot of symptoms, and then one more small one or one a little bit larger, and then there's a cascade, and all of a sudden you notice that there were problems. And how we know that is MRI scans are very good at showing that, and we might see somebody who's come in, you know, really disabled by a stroke, and we look at that MRI scan and we see that over time they've had a lot of small strokes. And if I have the MRI scan before I do my neuropsych and I see that on it, and now we're not trying to decide if it's vascular, we might just trying to decide if it's a combination of vascular and Alzheimer's, or something else, because I already know, and trying to figure out the extent of the effect on their everyday functioning with the neuropsych tests. But I'll ask them, I said, well, you know, have you ever had any strange experiences where suddenly you felt like you were going to black out or things seemed differently? And then as they start talking, well, I've heard this many, many times. I was out, it was really, really very hot. I think I may have had, you know, suffered from the heat, but all of a sudden my right side got very weak and I felt like I was going to collapse. And I don't know, it wasn't like I was sweating. And the spouse says yes, and he looked, or she looked different, and they were talking to me, and they were mumbling, and their words didn't make sense, etc., etc. And likely what they had either was a very small stroke that didn't leave any residuals, or they had a TIA, which by nature or definition resolves itself in about 24 hours or less. But one thing though, if you have that happen, even if it's a TIA, I tell people that's a warning shot across the bow, okay? It's nice that it resolved itself and it went away, but you need to get that looked at. You need to call your primary care physician. TIA is not something to take lightly, and get that looked at. Are you on medication for, you know, hypertension? And get other medical issues resolved. And as I said before, vascular dementia, it's not uncommon to see that occur with dementia of the Alzheimer's type or Alzheimer's disease. Dr. Mahinley mentioned this one, Lewy body dementia. This accounts for about 5 to 15% of the dementias that we see. Lewy body is kind of an interesting dementia. And I'll go through this quickly because that's not the main focus. But people with Lewy body dementia, as opposed to dementia of the Alzheimer's type, have very, very significant variations in cognition, in thinking, in memory, executive functioning, attention, throughout the day. So, you know, this is a very smart audience. You know a lot about dementia, and you know the sundowner syndrome. Okay, I don't even have to go into that. With Lewy body dementia, sometimes the family members or the people that know them think the individual might be faking because the change in cognition is so dramatic. At one moment, they can seem really out of it. Memory's gone, executive functioning, they're not paying attention, and then like a light switch, they're at baseline or near baseline levels in terms of their mental faculties. So it can fool people and they think, well, you know, maybe he's just acting, you know, just putting on a show or something. But it's not. It could be Lewy body. The other thing, sleep pattern changes. And I've interviewed spouses and loved ones. Obviously, when I see somebody for a neuropsych, I love to have collateral data. I like to have the spouse, family member, child, whoever has a good knowledge base of that individual come in. Lewy body dementia typically has REM sleep disorder. Now this is a horrible thing for the person sleeping next to the individual with Lewy body. Because you know, we have dreams, but the way our bodies function, the neurology of our bodies is we don't act out our dreams. Okay, so we're not trying to jump off the bed like Superman or something like that. We stay in bed. Unfortunately, the individual suffering with Lewy body dementia acts out the dream. So they thrash around on the bed. The poor person sleeping next to them might end up with bruises because they're running in their sleep, they're flying in their sleep, maybe they're fighting somebody in their sleep. And I will hear the spouse say, I can't sleep with so-and-so anymore in the same bed because they're all over the place. They've thrown me out of the bed, they've hit me, they've run over me, all that. So that kind of combination is highly suggestible. The other thing is, because of the REM sleep disorder, they have almost what you would see would be narcolepsy. During the day, they'll fall asleep at the drop of a hat. Now, I know you know, we might take a power nap or something like that. You watch a little TV and you fall asleep. Generally, in this sleep pattern, they just sit down and they're out. Boom, just like that. And then they have hallucinatory experiences. And I worked at the state hospital. I was out there for 27 years. Not out, I mean, I worked out there for 27 years. Get that straight. Schizophrenics who have hallucinatory experiences, the vast majority will share with you that they are not pleasant. They are very frightening, scary experiences. And hallucinations, as Dr. Mahinley had mentioned, they are real at the time they are happening. They are absolutely real, and you cannot distinguish between reality and the hallucination. We call the Lewy body dementia hallucinations. Typically, they're visual hallucinations. They see things that aren't there, and many times, most of the time, they're what we are known as benign hallucinations. In other words, they're not frightening to the individual. And they'll say, oh yeah, mom and dad came to visit last week. Well, mom and dad are deceased. Yeah, they came in, they were just sitting around the house, and, you know, my cousins who live out in California or something, they're not here. The little kids came walking through the house, and it was nice to see them and everything. So they're not frightened by them, and typically they don't talk. They're visual hallucinations, so there's not the auditory hallucination part where you would hear the voices. And generally, again, with schizophrenics and people with major mental disorders, most of their hallucinations are auditory rather than visual. And then you get Parkinson-like movement with Lewy body dementia. So that's some of the distinction there. Frontal temporal dementia, or Pick's disease. I'll go into, again, a little bit of this because clinically it's very important to differentiate between the two. And one of the things that happens, which can be confusing, and we'll talk about it in a minute, there is Alzheimer's dementia, which is early onset, familial or inherited dementia that occurs very, very early. Well, the same thing with frontal temporal dementia, or Pick's disease. It occurs very early. Atrophy of the frontal lobes, which is the personality, impulsive behavior, and temporal, which often has to do with some parts of thinking and some parts of memory. Now, frontal temporal dementia can take two paths at the beginning, two separate paths, which is important for us to know clinically. One is what's known as the primary progressive aphasia, the inability to either use, state, or understand speech. And it is dramatic. I've had people who come into the office with their spouse and they cannot, the patient cannot give me a history because they can only say one or two words and the rest of the words are just kind of general words. They cannot communicate at all. Or if they do communicate, it's communication with a lot of words that don't mean anything. Just stringing together, I can't even do it. I can't even mimic that. But that is, it's very, very apparent. So the beginning of frontal temporal dementia can take that pathway, or it can take the pathway where there are dramatic changes in personality. So the individual who is more an extrovert becomes an introvert. The individual who is more an introvert may become an extrovert, and it's quite dramatic. There's a violation of social norms. They may engage in shoplifting, sexual inappropriate behaviors, and that's because of the frontal lobe, which is our personality, basically, and also our ability to inhibit impulses and to read social cues has been decaying or damaged. But it starts early. Oh, all right, great. Self-knowledge question. Now we got a tougher one. Let's see how you all do. Okay, everybody read it? I see some puzzled looks. Okay, who says number 1? Okay. Who says number 2? How about 3? How about 4? How about I don't want to answer? The answer to this one is number 1, the hippocampus. I know I haven't spoken about it, but that's hippocampus. A nice small piece of the brain, kind of buried deep in there, but that's the part of the brain that is responsible for consolidating new memories. And as you know, people with dementia have what we call antegrade amnesia. In other words, the problem is the formation of new memories. Hippocampus is very responsible for that. It starts to deteriorate and new memories aren't formed so well. So when you speak with somebody, like my mom, for example, she's at that stage where we'll tell her something and 10 minutes later she'll ask a question about it. The memory hasn't formed, okay? Hippocampus deterioration. Here's my clicker. Dr. Alzheimer. That's who, obviously, the disease bears his name. Just a little bit about that. He met Augusta Dieter in 1901. He was working at a sanitarium. In 1906, she dies. Now, as the good German psychiatrist, he was actually a psychiatrist, but they also spent a lot of time doing autopsies and studying different diseases. So as the good Dr. Alzheimer was, when he took an interest in Augusta Dieter because she was kind of unusual in the sanitarium. Most of the people there, you know, had manic depression or bipolar disorder or schizophrenia, but she had some hallucinations, but the schizophrenic people and the other people didn't have that severe memory decline. She was about 55 years old, I think, when she died, in her 50s. And she had the memory decline, which was not common in that sanitarium. So I don't know how this all happened. Anyway, he left that place in 1906. Apparently she dies. Somehow he gets a hold of the body or the brain. I don't know how. But he does the autopsy because he was so interested in it. And you know what he found back over 100 years ago? Extroverts. You know what he found? He found shrinkage. That's right. That's right. He found, guess what? He found tangles and plaques in the brain. Now, doesn't that sound familiar? Over 100 years ago, Dr. Alzheimer did his autopsy, and he found those tangles and plaques that we're still talking about and dealing with today, right? So it's not something new. Tangles and plaques are not something new. What we know about them and how they form, etc. is, but having discovered those, that's over 100 years ago. All right, this is what I had mentioned this somewhat earlier. The 2 types, I'll talk about this because it's important. Early onset, familial or inherited type, and the late onset, which we're much more familiar with, makes up about 95% or more of Alzheimer's disease is the late onset variety. Look at this, I discovered I can actually put my papers down and get to them. Wow. And remember where they are too. Okay. But I can't handle all of it at once, so I really need somebody to be my clicker. Early Alzheimer's. Typically this date of onset is 40 to 60 years of age. And as I mentioned, less than 5% of the diseases of Alzheimer's disease is due to early onset. There's been a lot of research on early onset. There are big databases where they followed families. Actually, you can go on the internet and see some of the interviews with some of the family members. And it involves beta amyloid and plaque buildup. But the unfortunate aspect of it is that there's a 50% inheritability chance in offspring, which is a very high number. And if you listen to some of those interviews, and they're very poignant and very touching of the family members. And I remember seeing one, they had 20 to 30 people together, the different generations that they were talking to, and then you get to some of them, and holy cow, he's giving me the sign. I gotta move on, I'm sorry. Okay. But you're giving me the extra time that Dr. Mahenley used up, right, or no? Yes. I'm trying to negotiate here. Okay, so Alzheimer's disease, Alzheimer's dementia accounts for 60 to 70% of that 98% of irreversible dementia. So by far it's the most common and most prevalent. Typically we don't diagnose it until the late 60s, generally early 70s. The typical first presentation, memory problems, okay? Not something that that you've heard about it, you're a wise audience, you know about that. The general lifespan over the course of the disease, 8 years after diagnosis to perhaps 20, and the 20 years usually is somebody who is in very, very good physical condition. I gotta move, I'm sorry folks. All right, a little background. We're not really going to go into a whole lot of brain neurophysiology, but I think this is important. This is your neuron. I can't step too close. I wish I had a pointer. Oh well. Anyway, the neurons are the workhorse of the brain. The adult human has about 100 billion neurons in their brain. I can't even write that number. Also, what's important, not how many neurons, but the number of connections between neurons. And those are the things that start to fail often in Alzheimer's disease. We have about 100 trillion connections between neurons in the brain. Neurons don't touch each other. There's a little gap, synapse, and the messages are sent across neurochemically. So that's all I'm going to say about that. Okay. Two things happen, and I'll use this model. I think it helps. The plaques, you have the beta amyloid plaques in the brain, and you have tau. Beta amyloid, or the amyloid, is actually part of the brain. It's not a toxin at first. Think of an orange, okay? Think of an orange with a toothpick in it. The orange being the cell body, the toothpick being the beta amyloid. Part of it is inside the cell, part of it is outside the cell. There are other proteins that come along and snip off the part that's outside the cell body. Now, mutations occur, which would be changes. If it's snipped right, that beta amyloid is washed away and just as a toxin taken away. If it's not snipped right, it doesn't get dissolved. So it starts floating around in between the cells. And other ones start to get not snipped right. And the thing about the beta amyloid, it's very sticky. So they start to clump together. They adhere to each other. And what that does is interfere on the outside with the ability of cells, brain cells, to communicate with each other. And that's a problem, because if they're not communicating, things aren't working right for us. The other thing that happens is with tau, another protein. Now this happens actually inside the cell. The tau, think of this, and I didn't make up these descriptions, but I think they're very helpful. You have that axon that's part of the neuron. And in there, nutrients flow back and forth for the cell to stay healthy. Now, think of those nutrients as running along a railroad track, okay? The train running along the railroad track is carrying the nutrients. And you have the rails, and you know the train, those rails have to stay parallel, they can't be jutting in and out, doing crazy turns, things like that. Tau is the railroad tie that keeps those tracks parallel. what happens is the tau starts to deteriorate. The tracks start to bend, twist, and tangle, and the cell is not conveying nutrients throughout its cell body, and what you get is a cell starting to die from the inside out. Two different processes, one on the outside, one on the inside, both bad. Okay, quick one. I'm not going to give you much time, read fast, this is speed read time. So I'm going to get into speed talking in a minute. Okay, so, number one. Votes for number one. Votes for number two. Votes for number three. That would be Mahendele. Votes for number four. Okay, number one. That's a bad sign, okay? Because you've been to that grocery store many, many times, and now you're having trouble navigating there. That's one of the things we look at. There are different types of cognitive decline. You remember at the very beginning I talked about mild cognitive impairment versus getting to dementia and the different stages of dementia. Well, prior to mild cognitive impairment, we have what we call age-related cognitive decline, okay? And that's where you occasionally forget your keys, etc. like that. Age-related cognitive decline has to do with changes in the processing speed, the ability of our brain as we get older. Just like we cannot run as fast, jump as high, lift as many weights, do as well in spin class, Miss Renee, as we did when we were younger. She used to be my spin class instructor before she became a nurse. Sorry, Renee. But just like as we get older, we're not as capable as doing that. Same things happen with our brain. It's just not acting as quickly. That is not a cause for alarm. When I do neuropsych testing, or anybody does neuropsych testing, they will compare your results with individuals your same age, same sex, and same educational background. In some cases, whether you're right-handed or left-handed, depending on some of the tasks that you do. And that's because I can't take somebody who, like myself, is 63 years old and compare those results to somebody who is a freshman, sophomore, or junior in college. That's ridiculous. Our brains are different at this point. I have to be compared to somebody else in my normative group, and that's what neuropsych testing does. So anyway, moving on, 12 to 15% of people with mild cognitive impairment develop dementia in the first year. Mild cognitive impairment is kind of the first step that we recognize where there are some very mild, noticeable changes in how our brains are working. They don't interfere significantly with what happens during the day, but other people are really starting to notice that we're doing things differently. We have more problems balancing the checkbook. What used to be easy takes us a great deal of time. In the past, maybe we could just drive someplace, and now we have to think more about how we're going to navigate over there. Sometimes, oh gosh, I'm not looking at you back there anymore. Okay. Predictors. You can see, I mean, this is pretty apparent. Greater neurocognitive impairment means that the earlier there are more, let's say early memory difficulties are quite severe, that suggests a rapid transition from mild cognitive impairment to Alzheimer's. Multiple domains. Let's say when I'm testing the individual, not only do I notice that they have memory problems, they seem to have language problems, they have problems with attention, concentration, and focus. Those are problems in more than one domain. That means, once again, deterioration is happening more rapidly. Other risk factors, as I mentioned, cerebral vascular disease, diabetes are other risk factors that certainly can promote the transition. Self-knowledge test. I'll just give you the answer on this one. Is that all right? No, actually it's African American men. Because, and the thing is the age factor. The biggest behind, there are two very large risk factors. One is age, and the other, well, female is a big risk factor. Okay, but age is also probably the biggest risk factor. So, we don't know about the risk factors for mild cognitive impairment MCI. We think they're probably the same as they would be for dementia, but we really don't know. Family history is very important for late onset dementia. If you have no family history, taking into account the other risk factors that we talked about, probably your chance of getting it is around 10%. If you have a family history like I do, the risk factor goes up to at least 20%, maybe more. There are genetic contributions. It's not just one gene. That's why this thing is so hard to pin down. We think there's probably about 30 or so genetic factors in Alzheimer's disease. Genetic factors, basically non-modifiable. But there are modifiable risk factors that we can take into account. Educational level, there is a correlation between the higher the educational level and the less rapid progression of the disease. I just know this about correlations or associations, and even when you hear this on the news, you know, oh, there's a relationship between such and such and such and such. A correlation is not a cause and effect. It just says that there's a relationship between two things. Okay, so it doesn't mean I went to school longer, that's going to cause me to have less chance. Going to school is the operational factor to not get Alzheimer's disease. It just seems to be a relationship. I don't know. Exercise and physical activity, I'm sure you know about that. Certainly control of vascular risk factors. If you have things like hypertension, stay on your blood pressure medication, take your blood pressure, take care of yourself, get some exercise if it's not contraindicated. Remaining socially engaged. Time out. Oh, am I really done? All right. I'm sorry, folks. I didn't time it very well. I do have other things. Can you give me two more? No, all right. Okay. Here we see, I gotta point this. This is the frontal lobe right here, prefrontal cortex, temporal lobe down here, hippocampus in here. That's the brain, obviously. I'm sure you know that. So in the early stages, that bluing in there is showing you the beginning stages. Hippocampus right in here, that's the memory. Frontal cortex changes, some of the changes in executive functioning. Did you see that? I stepped over the wire. I'm so proud of myself. All right, mild to moderate. Look at the progression in Alzheimer's disease. More of the, I almost didn't make it that time. More of the frontal lobe, darker bluing, spreading out more through the temporal lobe. Two speech centers, one here, one here. One primarily in this area for understanding speech, making sense out of speech, and one for expressive speech. They're starting to be affected at this point in time. Severe stage, you have more of the atrophy. Look at all this bluing. You can see how the whole cortex now is starting to be affected. Okay? All right. Neuropsychological evaluation. It doesn't take 5 hours. That's me trying to figure out what the heck I got. Scoring up all the tests. It takes about 3 hours. The neat thing about going to see a neuropsychologist, and I hate to say this, we get paid like attorneys for time, okay, not by severity of disease. So I take time with everybody, and I really want to learn about them and learn what's going on before I actually start doing the test. Anybody who has claustrophobia, ever went in an MRI scan? Woo! Better take your Xanax, okay? Because if you're claustrophobic, that's going to be a rough test. And what I like especially is there are no injections, because I don't like injections. Also, it doesn't require fasting, and people say, oh, that's kind of neat. But it does require brain work, okay? I mentioned these already, 7 domains that we typically test. This is what a graph looks like. I know it's hard to see. This is a patient with confirmed Alzheimer's disease. The reds and yellows are not good, okay? Up here is all memory. You can see the effect on memory. So this says moderately impaired, this is severely impaired, this is kind of in the middle, and you can see the extent of the yellows, reds and yellows in there, and it's more widespread. This is the IQ. It even affected this person's IQ. Okay, over time that's going to happen. This is some visual spatial skills, so that's still pretty good. She's still able to understand information pretty well. Going into, this is the average range, that green is average, but you can see generally, I want to get to this one. Mild cognitive impairment associated with high IQ. And I have to look at my note here for a second, because I know this individual had an MRI scan, and I can't remember what it says. Bear with me just a minute while you look at that. I know it's not very clear, and I'm taking up more time, but I'm not looking in the back of the room. I know, I don't work well with authority, I guess. So this is a 78-year-old male with a high school graduate, very high IQ, real IQ, not the internet IQ, and the MRI said unremarkable. But I was able to discern, so I'm going to go back and forth because my technology isn't good enough to put two. This is his IQ, this kind of blue. And his IQ was in the superior range. Okay, and that's pretty darn good. Take it from me, that's pretty darn good. You can see his processing speed has slowed down. With an IQ like this, his processing speed shouldn't be below average. But it's below average right now. These are involved in executive functioning, so there's some variations in his executive functioning. Again, if everything was okay with an IQ like this, there shouldn't be a yellow thing over here. These should be they shouldn't be yellow down here. There shouldn't be those kind of changes. And we look at some of the memory scores. His delayed memory composite, I'm not going to go into that, but it's below average. Now somebody with an IQ like that, where I've ruled out, and Dr. Mahinley has ruled out other causes, metabolic, psychogenic factors such as depression, anxiety, etc., that should not be interfered with. So this was confirmed, mild cognitive impairment with high IQ. And that goes again to the point, we caught this rather early for this individual. A lot of individuals with high IQs are able to compensate day to day, but the neuropsych testing picked it up. At this point in the process, his MRI was unremarkable, but we can see that certain things are going on. And we know in the treatment of many diseases, just about done, in the treatment of many diseases, the earlier we can intervene in the disease process, the better the outcome. And that's why it's so important for us to get a handle early on in this disease process, so we can intervene before changes occur that we cannot reverse. All right, thank you very much. I enjoyed having the opportunity to talk with you. I guess I better turn it over. They're going to get that grab bar and just pull me right off the stage.
Thank you so much, Dr. Goldman, and here is a token of our appreciation.
Thank you, Dr. Thank you, Dr. Goldman, for that great presentation. And also just a reminder that if you have any other questions, he'll be here hopefully for maybe a few minutes. And also that we have a fabulous website that you can visit at any time, the ALZ.org, that has great information, different forms of dementias, different diagnosis, what's going on, what's the latest research that you can visit. It's award-winning and you can benefit from it whether you're a family caregiver or you are a professional in the community. We are going to break for 10 minutes. 5 minutes, I'm sorry, Joe has corrected me.
Blame it on me.
Yep, it's Dr. Goldman's fault. In the meantime, if you have filled your cards, please leave them on the table. We're going to collect them. When we come back, we're going to do one raffle of prizes from the generous donation from our different vendors. And then we're going to continue with Dr. Ripstein thereafter shortly. Thank you. I just remembered the door.
Where did the years go so quickly, my love? How did we get to be gray? Decades go by in the blink of an eye. It still feels like just yesterday. The first time that I heard you say, love me forever and hold me right now. Gather our memories like this. I know we'll never be old anyhow. Anytime we reminisce, I'll be as young as you.